hari Sabtu cuti, Ahad cuti ya?
Sabtu sebahagian, Prof. Sebahagian masih bekerja.
Okey. Dr. Andrina dengar kejap ya. Boleh dengar suara saya?
Dengar, Prof.
Sekejap ya.
Ya.
Sepatutnya pakai headphone. Hello?
Iya, Prof. Jelas,
Okey.
Prof. Ya.
Sekarang suaranya lebih jelas tak?
Ya, lebih jelas, Prof.
Lebih jelas.
Lebih merdu.
Lebih merdu. Pukul berapa kita patut mulai ya, Doktor?
Ini Dr. Arfiza.
Yeah, already 9 o'clock in Indonesia. Maybe Dr. Andrina can open the this meeting.
Thank you, Dr. Arfiza.
Recording in progress.
Assalamualaikum warahmatullahi wabarakatuh. Puji dan syukur kita panjatkan kehadirat Allah Subhanahu wa Ta'ala karena kita diberikan kesehatan, kesempatan untuk berjumpa kembali pagi ini untuk sharing ilmu dari Prof Marina. Salawat dan salam kita tujukan kepada Rasulullah Sallallahu Alaihi Wasallam. Pertama-tama atas nama Departemen THT-KL Fakultas Kedokteran Universitas Sumatera Utara, saya ingin mengucapkan terima kasih yang sebesar-besarnya kepada Prof Marina Baki, PhD dari UKM, karena untuk kedua kalinya sudah bersedia memberikan materi pada pagi hari ini, sharing ilmu, sharing experience. Terima kasih Prof atas kesediaannya. Saya ucapkan terima kasih kepada Ketua Prodi Dr. Devira, kepada Moderator Dr. Arfiza, dan seluruh peserta kuliah tamu pada pagi hari ini. Insya Allah apa yang kita dapatkan pada hari ini akan memberikan manfaat bagi kita semua. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Andrina, for the opening speech, and good morning, everyone. Welcome to our Inviting Professor online seminar. This program was held by Otorhinolaryngology Head and Neck Department of Universitas Sumatera Utara. Today we have the second time from the Prof Marina Baki from the UKM. Hello, Prof.
Hello.
Good morning.
Morning.
Okay, she's just a reminder for you all. She's a senior consultant of Otorhinolaryngology Head and Neck Surgery of the Hospital Tengku Muhriz University Kebangsaan Malaysia. Subspecialized in laryngology. She was awarded in her PhD in the laryngology for University College London in November 2014. This morning, she will present of the videostroboscopy, and this topic is very, very interesting for diagnosis in the laryngology. If you have any question, please type into the chat box, and Prof. Marina, the time is yours.
Thank you, Dr. Arfiza, for the very kind introduction. And thank you, Dr. Andrina, for having me here, inviting me to give this lecture. So today would be the second lecture of the year. The topic is videolaryngostroboscopy. So I will try to make it interactive. There would be the participants or the audience can ask questions in chat box. And also maybe we can allow live question if Dr. Arfiza allow them to do so. I would have some videos which probably I will pick up one of the residents and let me know if I wrongly picked a resident, like I wrongly picked Dr. Andrina. So sincere apologies because of that. So another thing that I want to say is there are many videos in my lecture. So when I play the videos, I would keep quiet until the video finish because I realized that if the video have some sound and I talk at the same time, the audience wouldn't be able to benefit and they wouldn't be able to hear my voice clearly. Okay, so let me share the slide. We have 80 participants, yeah. And how many of them are residents?
Maybe most of them. Prof.
55. 55, yeah.
55,
Or, yeah.
okay. So I'm so sorry if I picked a specialist instead of a resident to answer some questions. I hope you don't mind. So the topic today is on videolaryngostroboscopy. In the lecture, we would focus on the diagnosis, how we are going to assess, and so show some videos, yeah, and then you may want to guess the diagnosis. I wouldn't include the management into these slides because the topic is on focus on the videolaryngostroboscopy, which is an important tool in helping us to assess and diagnose vocal fold findings, lesions, or patients with voice disorder. This is the complex of UKM, University Kebangsaan Malaysia. So these are the learning objective. Number one, we want to know, probably by the end of the lecture, you would be able to understand about recent advances in endoscopic imaging technologies. Today, we're going to focus on videolaryngostroboscopy. I think the next lecture, we're going to focus on enhanced imaging technology or digital chromoendoscopy. And number two, for you to understand the principle of videolaryngostroboscopy and how would you assess the mucosal wave. Number three, for you to understand the clinical applications of advanced laryngeal imaging. For today's contact is videolaryngostroboscopy. So this is the content. We're going to talk on basic principle of stroboscopy, laryngostroboscopy, findings assessment. I would show some case demonstration. And the last bit, I would let you to guess the diagnosis when I play the video. Right, so this is what we have learned a month ago, the protocol of voice assessment, which is an important area that we need to make sure that it happens when we manage patients with voice disorders. So we have voice-specific self-reporting outcome. I have talked about voice handicap index 10. Okay, there are other type of self-reporting outcome like voice, VRQOL, and so on. Number two, we have voice perceptual evaluation by professional raters like Dr. Andrina. When Dr. Andrina see patients in the clinic with voice disorder, then Dr. Andrina would start evaluating what is the overall dysphonia, is it a predominantly roughness or predominantly breathiness, and how bad is the roughness and breathiness component. And number three is measurement of subglottic pressure, which we talked about. If you don't have extravaganza instrument, you can do maximum phonation time to measure this, the glottic efficiency. And we talked about computer software that enable you to measure the vocal quality, namely fundamental frequency, shimmer, nosoharmonic ratio, vocal intensity, and so on by doing acoustic analysis. And number five is videolaryngostroboscopy to examine the vibratory characteristics. So today is the focus of the lecture, the videolaryngostroboscopy. So now we're going to talk on the principle. We need to understand how does it work, How can we visualize the mucosal wave so that we would understand why there is a need of such light for us to visualize the vibration of the vocal fold. stroboscope is not something new. It has been there for a long, long time. And ENT or otorhinolaryngology is not the only department that use this stroboscope. Yeah, many the engineers maybe use. Yeah, some other departments may use. Okay, what is it? Stroboscope. It is an instrument that make a cyclical. It has to be cyclical. Yeah, moving object to appear slow moving or static. Okay, so how can we make the cyclically moving object appear slow or static? Is by giving the object or emitting light, flashes of light on the cyclically moving object. I'm going to show a video after that. And the frequency of flashes of light that is emitted on the moving object has to be adjusted according to the frequency of the moving object. Okay, if the frequency is exactly the same, you would see the moving object does not move, meaning it's static. Yeah, but if you delay the frequency of light by few seconds, you would see the moving object appear like slow motion, yeah, moving slowly. So this is stroboscope. People have invented long ago, and in 1878, quite long ago, Ortel had pioneered the use of stroboscope in laryngeal endoscopy, which he coupled stroboscope with laryngeal endoscopy for us to examine the vocal folds. So I got this video from a YouTube. Okay, I'm going to play the video. The man is going to put a blade that white and black in color. I'm going to put here on a cyclical moving device that allow the blade to move around. Okay, like that. Okay, and then it's going to switch on. We're going to see that when the subject, like our fan, yeah, initially you wouldn't be able to see the blade, and now flashes of light is emitted on the moving object, and they adjust the frequency. When the frequency delayed by few seconds, now you can see the blade like moving in slow motion. If they adjust the light to be exactly the frequency of moving object, the blade would appear like not moving, static. Okay, so that is the principle of stroboscope. So in normal vocal folds, yeah, whenever we phonate, there is frequency. Okay, what does it mean by frequency? The frequency means how many glottal cycle the patient or the person can achieve within a second. For example, if I say and then the object or the acoustic analysis picked up that my frequency, fundamental frequency of my voice is 250 hertz, meaning there will be 250 glottal cycle of vibration in 1 second. That is impossible to be seen with naked eye. Yeah, for example, in a paper, it says that in male, the vocal fold can vibrate 70 to 500 times in 1 second, meaning the hertz of male voice, and female voice, it can go up to 1000 hertz. So this is so impossible to be seen with naked eye. So therefore, when you emit a stroboscope light, flashes of light that match the frequency of the voice, which not exactly, just delayed by few seconds, then you would see the vibration of the vocal fold like a slow motion. Then only you can examine whether the vibration is normal or not. Okay, after this, we're going to talk about why is it important to examine the vibration of the vocal fold. Okay, so this is another thing that I want to make everyone understand. Many people confuse what is laryngoscopy and what is laryngostroboscopy. Laryngoscopy is just our laryngoscope, yeah, the one that we normally use in the clinic. Either we use 70-degree scope or flexible scope, mainly to see crude movement of the vocal fold, the abduction or adduction, okay? and to see any obvious structural changes on the vocal fold, like big cyst, big tumor on the vocal fold, vocal cord palsy when the one side of the vocal cord is not moving. Okay, that is laryngoscopy. However, when this laryngoscopy is coupled with stroboscopy, okay, it is called laryngostroboscopy. And the job is not just looking at the crude mobility, but the main job is to look at the vibration, the mucosal wave during phonation, not during respiration. There wouldn't be any mucosal wave during respiration because the vocal fold will be abducted. The vibration, the mucosal wave will be produced during adduction, during phonation, because this is when voice is produced. So in Greek, strobos means whirling, while scoping means watching and observing. Okay, that is how they got the name of stroboscopy. So when the light of the stroboscope match, I've mentioned this already, I'm not going to repeat it. Okay, so now, before we talk more about mucosal wave, we need to understand about layers of the vocal fold. Okay, any defect at the any layer of the vocal fold will cause hoarseness. Okay, will cause voice disorder. Okay, remember, voice disorder and speech disorder is different. Someone who have hypoglossal nerve paralysis, the person may have normal phonation. The voice is that produced by the larynx is normal, but the problem is articulation. The speech becomes slurred. Okay, so what we are examining here, not the slurred speech, but the abnormal mucosal wave during phonation, which is affected by any pathology at any layers of the vocal fold. So this is something that you need to understand. The vocal fold consists of a few layers. Okay, you need to read about body and cover theory by Hirano, which the cover is the outmost, the most medial part of the vocal. This is cross-section, coronal view of one side of a vocal fold. So the outermost layer is the squamous epithelium, and after that, beneath that is superficial lamina propria. So this is considered as cover, whereas the body is here, the most medial part, which consists of vocalis muscle, the vocal muscle, and between there is vocal ligament that consists of intermediate and deep vocal ligament. Okay. Now, when vibration occur, it occur, when there is close, open, and close again, the vibration because of movement of air from the subglottis, from inferior to superior. The one that is vibrating is the cover, okay, which is the epithelium and the superficial lamina propria, which the vibration is like someone dancing. So if someone is dancing, it is not just the dancer important, the floor of where the dancers are dancing is also important. If the floor is not rigid, is not smooth, the dancers would have problem to dance smoothly and beautifully. Okay, similar like the vocal fold. If let's say someone have a normal epithelium, normal superficial lamina propria, but the body is problematic because, for example, vocal recurrent laryngeal nerve palsy, and the body become flaccid, become weak. So the floor where the vibration of this the cover layer want to occur wouldn't be rigid anymore. Okay, to produce a nice vibration. So in other words, any insult at the layer of the vocal fold, whether the body, the ligament, okay, which is part of the floor of the dancers, or the vibration of the vocal fold, superficial lamina propria, or the epithelium would affect someone's voice, causing voice disorder. All right, so this is what we want to examine by using video stroboscope. We need to see the free motion of the mucosal wave, okay? And by examining this, we would be able to come up with a proper assessment and give a proper, a more accurate diagnosis. So having said that, someone who have unilateral vocal cord paralysis, you don't need a stroboscope to diagnose one side vocal cord is not moving. Laryngoscope will be able to do that. But there is something else that you can assess, yeah, the vocal fold when you use a stroboscope. Another example, you may have a huge vocal cord cyst on the vocal fold. For you to see the cyst, a big cyst on the vocal fold, you don't need a stroboscope. Okay, the normal laryngoscope you can see, but there is another more detailed things that you can assess, yeah, on the vocal fold that has cyst, which I'm going to show afterwards. So in a videolaryngostroboscopy system, I'm showing this because this is the stack that I am using. So I'm familiar with this system. Out there in the market, there are other stroboscopy system, which the principle may be the same, but the components may be slightly different. So here we have display monitor, and you can see there are a few stacks over here. The uppermost stacks is called high definition video processor. Okay, so this processor produces static xenon light. Okay, and within this also, it provide digital chromoendoscopy for enhanced laryngeal imaging. That would be the topic of the next lecture, probably next month. Okay, and the second stack is the laryngeal strobe processor. Okay, so this is the stack that produce flashes of light, okay, for us to examine the vibration of the vocal fold. And the third stack over here is digital video capture module. It is like a CPU that has a software in there. So with this software connected to the stroboscopy and HD processor system, it enables the examiner, number one, to save the video, number two, to analyze the video. Okay, so without this digital capture module, you wouldn't be able to analyze and you wouldn't be able to save your examination, and you wouldn't be able to play it again. So that is the beauty having this digital video capture module, right? So, and then we move on to other parts of the stroboscope. Other part of the stroboscope which is very important is microphone. So remember, the stroboscope must emit light with a certain frequency. So the frequency of light emitted wouldn't be the same in each patient. Okay, it would depend on what is the frequency of the patient's voice when we are examining the patient. Okay, for example, when the scope, the flexible scope is in there, showing the larynx and the vocal fold, and you ask the patient to say E, the frequency of my E is different from the frequency of Dr. Arfiza's E. So we need to put microphone at the neck of the patient so that the stroboscope will be informed what is the current frequency of the patient's voice that you're examining, so that the stroboscope will adjust the frequency to enable us to see the vibration of the vocal fold in slow motion. It's the similar like principle of stroboscope that I have explained earlier in the earlier slide. So therefore, if you see this picture, this is an old system of stroboscope by Pentax. Okay, you can see that the microphone is tied on the neck, on a strap. Yeah, this one is important. Let's say you forgot to bring the microphone to the neck, just put the scope in, you tell the patient to say E, you wouldn't be able to see the vibration. Okay, because the stroboscope processor confused. Come on, tell me, what is the frequency of patient? You're not telling, you're not giving that information to the stroboscope. This is a new stroboscope processor. If you look here, within the circle of red, it says their frequency. So whenever you're examining the patient, when the patient is phonating the microphone in the neck, you will be able to see the frequency of the patient's voice here. Okay, the fundamental frequency. Now, another part of laryngostroboscopy is the endoscopy. Those days, we use 70-degree scope, yeah, for laryngostroboscopy. Okay, there are still some stroboscopy provide 70-degree scope. However, nowadays, with the advent of technology, we can perform laryngostroboscopy using video endoscope. Okay, it is different from fiberscope. Yeah, there's one slide I'm going to show you the difference between fiberscope and video endoscope. Video endoscope is preferred because the camera is at the tip of the scope. Yeah, and as you can see here, the camera is not here. Like, you know, our usual flexible scope, you can detach the camera head. That is fiberscope. Yeah. So the usual fiberscope that we use, the head is at the beginning of the scope, whereas the lens is far below. So therefore, the image that you get captured by the camera wouldn't be that clear. Yeah, wouldn't be sharp. Whereas in video endoscope, the camera system cannot be detached from the flexible scope, and the camera is exactly at the tip of the scope. The nearer the scope goes to the vocal fold, the clearer the image that you would be able to get. And what this is the stack that we have been using. You can see this is a video endoscope. Okay, and now this is video processor HD, which when we want to use this, we have to move the light source to here. Whenever we want to change the stroboscope light, my assistant would move the light source to below. Okay, so what are the advantages of using flexible video endoscope rather than 70-degree scope? Number one, it would enable laryngeal examination in patients with excessive gag. I'm sure that you have experienced this, 70-degree scope. The moment the scope touched the base of tongue, the patient would start gagging, and it is almost impossible to examine those patients. Also, it helps to examine the anterior part of the vocal fold in patients with anterior larynx. Yeah? I'm sure you have experienced this. Whenever you put 70-degree scope, if the larynx is very anterior, the petiole of the epiglottis is very anterior, you have difficulty to visualize the anterior commissure, which maybe the pathology is there. You may miss if you don't visualize that. And another advantage is by using video endoscope, when you examine the larynx, you can do different kind of phonation tasks. Yeah, you can tell the patient to sing. You can tell the patient to say rainbow passage. When the sunlight strikes raindrops in the air, it acts like a prism and form a rainbow. The patient can do that. Whereas if you put 70-degree scope, the patient would just be able to say "ee" for just a short period of time. The patient wouldn't be able to stand if you put the 70-degree scope so long, yeah, at the back of the tongue. And by having this system as well, at the same sitting, you can perform laryngeal procedures like injection laryngoplasty for Botox injection or hyaluronic acid injection, which I'm going to show in next lecture. Okay, so this is a stroboscope. Yeah, I'm going to play this. Okay, is that clear, Dr. Arfiza?
Clear, Prof.
Can you hear the voice?
Yeah.
Okay, so then you notice that the vocal cords are in adducted position. The patient is doing phonation, and there is close, open, and close again. If you remember my previous lecture about mucosal wave, about glottal cycle, this is what happening. Yeah, the subglottic pressure build up, energy from the lung, the vocal folds are adducted. The building up of the subglottic pressure will push the adducted vocal folds slightly open to let gush of air through through the vocal folds, yeah, the closed vocal fold. So when there is a little bit parted vocal fold, there will be a gush of air, then Bernoulli's phenomenon occur, where when Bernoulli's phenomenon occur, pressure drop, the vocal folds come back together. Okay, so every time gush of air through the vocal fold, this is when sound is produced. All right. So how do we evaluate stroboscope findings? Yeah, evaluation. This is something that also people, especially postgraduates, confuse. They thought that evaluation of videolaryngostroboscopy is objective. It's not that so. Yeah, evaluation of laryngostroboscopy is mainly qualitative. It depends on the raters. It depends on how skillful or how experienced the raters or the examiners in visualizing the mucosal wave. Okay, so to reduce the variability in assessment of one rater to another rater, from my assessment to Dr. Andrina's assessment, the researchers out there have developed a protocol, a tool, yeah, so that you can score and you can standardize the way you assess the stroboscope and findings, and the way you document the stroboscope findings. So mainly when you see the mucosal waves, what are the things that you need to see? Number one, you need to see the mucosal wave, whether it is symmetrical or not. You need to see the glottal closure. You need to see the amplitude of the mucosal wave. Okay, so here I'm showing you an example of tool that you can use when you are documenting findings of stroboscopy. This is stroboscopy research instrument, which is developed and validated by Clark Rosen. Okay, I think you're familiar with Clark Rosen, Dr. Arfiza?
Yeah, Prof.
Yeah, so I mentioned Clark Rosen before. He's the one that shortened the voice handicap index from 30 to 10. Yeah, because voice handicap index 10. And he also the one that developed this tool, yeah, to help us in documenting stroboscope findings. Yeah. So when you see mucosal wave, okay, after this I'm going to show many videos. Remember this, and then every time you see the mucosal wave, you, number one, you tell yourself, you look at the mucosal wave, is it symmetrical or not? I'm going to show you after this what do you mean by symmetrical mucosal wave. Is it symmetrical or not? The amplitude, yeah, whether it is normal or not. You have to say it differently, right side differently, left side, and compare. Periodicity, whether there's any tempo in the mucosal wave. Is the mucosal wave is close, open, close at the same tempo? Or is there any irregularity, jittery in a mucosal wave? And then when you look at the vocal folds, you see, when you see the vibration, is there any part of the vocal fold which is not vibrating, yeah, which may indicate scar, which may indicate lesion on the vocal fold, causing non-vibratory segment. Yeah, you have to evaluate right and left differently. And duration of closure. Duration of closure means, some author call it phase closure. It means, is the glottal cycle normal or not? Yeah, do you remember last time? Close, open, and close again. So is it a normal glottal cycle? Is it a predominant close, half close, half open, predominantly open, or always open? I'm going to show a slide after this about duration of closure. And you need to see the type of closure. Okay, in normal people, they should have complete closure. Okay, and if you look at papers, okay, some people consider posterior glottic chink, a small one, considered normal. Okay, whereas other closure is considered abnormal. Incomplete closure is abnormal. Hourglass closure would indicate there's lesion at the midcord. Spindle shape, normally related with conversion dysphonia, okay, and anterior glottic chink can be related to muscle tension dysphonia, okay, but not always, yeah. So it's good to document. This is what I have been repeatedly saying in the previous lecture and today's lecture, mucosal wave and glottal cycle. So the subglottic pressure will open the adducted vocal fold from inferior, slightly open from inferior. This is still closed face because the vocal folds still come together. And now the vocal folds are slightly apart. Yeah? This is open face, open, 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 and close again. And the closure occur from below to superior as well. So from close, open, and close again, it is called a glottal cycle. Okay. And if someone have 250 hertz of fundamental frequency, that is 250 glottal cycle in a second. Okay. So hopefully you grab this knowledge, this understanding, this theory, okay? Now, with digital capture module, whenever you have saved the video, you can do one-step montage of a glottal cycle in which you choose the frame, okay? This is something that you can choose at the beginning of glottal cycle when the start of closure, and then you right-click, you click on montage, you would get this. This is a frame of a glottal cycle. Of course, in a glottal cycle, as I said, there's 250 frames probably, but the software choose only 10 frames here. Okay, so in a normal glottal cycle, it should be in a 10 frames. Yeah, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There's only 1, 2, 3, 4. 4 out of 10 open face. So this is considered normal. So we tick at the stroboscopy research instrument predominantly closed. Okay, let's say half of the frames open and half of the frame closed, right? 5/10 open, 5/10 closed. So you get half open, half closed. The maximum phonation time normally not too bad. It can be still normal. But when you see the closed face, maybe 1 frame or 2 frame only and the rest open, okay, you call it predominantly closed, predominantly open. And normally this patient would have breathy voice, okay, and they cannot sustain the maximum phonation time. The subglottic pressure is released rapidly because of ineffective closure. Okay, so this is possible if you use the montage, if you have digital capture module. Now we want to understand, when do you say the mucosal wave is symmetrical? You would say the mucosal wave is symmetrical whenever the vocal fold open. During the open phase, it open like a mirror image. Okay, as you can see here, the left side and the right side, whenever it open like a mirror image, exactly the same amplitude, exactly the same speed. Okay, and what does it mean by periodicity? Whenever there is tempo, open and close at the same time, meaning there is tempo in the mucosal wave. But if you see the mucosal wave is like jittery, there's 1 close, 1 open, 1 close, 1 open, so that is considered a periodic mucosal wave. Okay, so another parameter, yeah, in the stroboscopy research instrument is amplitude. So what is it by amplitude? Can you see the curtain effect? Okay, here. So you observe this wave that occurs from midline to lateral. It's like a curtain. Okay, so that is the amplitude. The far the curtain can go laterally, the bigger is the amplitude of the mucosal wave. The bigger is the amplitude, the better is the projection of voice. Okay, so then you compare the amplitude between left and right. The amplitude will be limited in patient with vocal fold stiffness, for example, scar, or patient with muscle tension dysphonia, where the false cord is pressing on the vocal fold. Therefore, the mucosal wave can't go very far, yeah, because it's been pressed by the supraglottic structure. or in cases of tumor, when there's infiltration of the vocal ligament. So therefore the amplitude will be reduced. The amplitude will be also reduced when there is weakened of the body, which is in vocal cord paralysis. Okay, so then the dancer cannot go very far because the floor is not strong, it's not rigid. Okay. Now, this is what I have said just now. Just I'm repeating the duration of closure. This is one glottal cycle, and on this side shows the montage of a glottal cycle: close, close, open, open, and close again. So, why is it important to have a one-step montage and frame-to-frame analysis? This is so that we can be more reliable in evaluating the mucosal wave. Okay, as I said, it is subjective in nature, and if you can do frame-to-frame analysis, it may enhance the reliability of the assessment. Let's say if I have frame to frame and then I analyze and then I give the video to Dr. Arfiza, Dr. Arfiza also analyze, do frame to frame, do analysis. My assessment of stroboscopy research finding when I score on the stroboscopic research instrument may be not much different from Dr. Arfiza. The variability is reduced because we managed to standardize it as close as possible. Of course, we cannot be exactly on dots, but we try to make it less variable, okay, and so that our assessment is more reliable. Okay, as the lecture go further each slide, any slide you're not sure, you can write in the chat, yeah. So here I'm going to show what do I mean by slow motion analysis, frame to frame analysis. Number one, you can use the one montage. Another one is you can do slow motion analysis bit by bit, yeah, frame by frame. Okay, I'm going to play this video. This is the start of a glottal cycle. Then we go frame to frame analysis. Close, still close. Close, 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 and then it opens. This is open face. You can see there's some irregular epiradiosity. Then it closes again. So I hope you can appreciate what do I mean by frame to frame. Yeah, you go one by one as it moves. Yeah, the close, the mucosal wave. Yeah, that goes from midline to lateral, from inferior to superior. You can see it here by doing the slow motion analysis. The start of okay. Now, I'm going to move on case demonstration. Do we have any question you want to ask about the principle of stroboscope, the assessment of stroboscope? Do you want to ask now, or shall I move to the next slide, which I would show some cases?
Is there any question from the audience?
Maybe we collect Dr. Arfiza. I don't see any from the chat box.
Yeah.
So that to save time, you please write in the chat box, and then I would continue with the lecture.
Okay.
Okay. The next slide. Okay. Again, I'm going to play this video for you to appreciate how does a perfect mucosal wave look like. Okay, now, right, before I go for case demonstration, just to make everyone understand, I've said this in the previous slide, you don't need laryngostroboscope to diagnose unilateral vocal cord palsy, to diagnose bilateral vocal cord palsy, to diagnose a big fungating tumor, You don't need stroboscope to diagnose a big cyst on the vocal fold. Okay, but there are other clinical applications, plus points if you examine the mucosal wave. Number one, you would be able to see any subtle vocal fold pathology that cannot be seen with naked eye. For example, scar. Just with, especially if you have fibroscope, it is hard to see scar, but yet the patient's voice is hoarse. You don't know what's wrong with the patient's vocal fold. To differentiate functional and subtle structural and abnormalities. Some patients have voice disorder, the vocal fold look pristine, no structural problem, but yet the patient has hoarseness. So by examining the mucosal wave, you would be able to predict what's wrong with the patient's voice and determine the next management. Okay, and I said you don't need stroboscope to diagnose vocal cord palsy, but it is helpful if the patient have to diagnose vocal fold paresis when there is reduced mobility, something that is subtle, not that obvious. And you can use this videolaryngoscopy to diagnose early stage of laryngeal cancer and the degree of infiltration of the lesion. It also help in, I have mentioned this, help in treatment decision, also help in tracking treatment progress. Okay, this is a case demonstration. A 23-year-old female college student complained of hoarseness for 1 year. I want to, hang on, yeah. All right, so I would like to play the voice of the patient. Can I have a resident to, what do you call that, do perceptual evaluation of the voice for me? Maybe Dr. Arfiza call the name because I don't know the residents.
Maybe in the laryngopharyng division. Wait, Dr. Vicky, maybe Vicky Hilman.
Dr. Baki, okay? Dr. Baki, ready? I'm going to play the video, yeah?
My name is Clavales. I come from France. I'm 20. I'm a student in a business school and I like to travel in Malaysia.
Okay, perfect. Dr. Baki, what do you think of the patient's voice?
Pardon, Prof. Maybe the voice is little bit British voice, Prof.
Sorry, I can't hear very well. Your voice is breaking. Can you hear the patient's voice or not clearly?
I cannot hear the voice.
Oh, you cannot. Dr. Arfiza, can you hear the voice?
Yeah, I can clearly hear the voice.
Maybe Dr. Biki's
Maybe,
line is not
yeah.
stable. Anyone else would like to try?
Maybe should aja Khairuna, maybe.
Khairina.
Khairuna, sorry.
Khairuna.
I'm here, doctor. I'm sorry, but could you please play the video one time again, doctor? Thank you.
My name is Clavales. I come from France. I'm 20. I'm a student in a business school and I like to travel in Malaysia.
Okay, perfect. What do you think?
It is the roughness of the voice is from the Graba scale. I would like to measure her voice is a G2. The roughness is 2. Breathiness is 0. Asthenia is 0.
Okay, thank you.
Thank you.
I agree with Khairuna, but I would say G1. G2, G1, okay. The variability is not big, okay. Not too bad, right? The voice. And at that time, I didn't have a video stroboscopy. Khairuna, can you see this video? And you tell me what is the possible diagnosis? Okay, can you tell me one possible diagnosis? Can you see the video clearly?
Yes, ma'am, but I didn't see. I see a little bit hyperemic area. Could it be laryngitis?
Laryngitis, okay. It's not, you don't really see any obvious pathology, right? But if you look carefully, there is, the mucus tend to go to the midcord, okay, and tend to meet over here. And it looks like she has nodules over there. Okay, and I hope everyone agree. This is fiberscope. This is what I said. The camera is at the top, which you can detach, and the image is not that clear. Okay, and it is dark, isn't it? And so then I give a diagnosis of vocal fold nodules. Looking at, you focus on the midcord, yeah, there is like mucus tend to go there. That is a telltale sign, yeah, when there are lesions on the vocal fold, mucus tend to go to the pathology side. And 2 months later, this is the patient's voice. Yeah, I send the patient for voice therapy, and this is her voice 2 months later.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. This takes the shape of a long, round arch with its path high above. And
what do you think of the patient's voice now, 2 months after voice therapy?
The roughness has been improved, doctor.
The roughness improved, okay. Yep, maybe similar. To me, the first one is about roughness 1, and I think there's not much improvement, or maybe worse slightly, to roughness 2, okay, right? But you are quite similar, your assessment with me. We are not talking about roughness 3 over here. And now I have videolaryngostroboscope. I'm going to play the video. Okay, now say E for me, long E. Do me a little bit of throat clearing. Okay. One more time. Okay, done. Okay, now long E. Long. Okay, now Hairuna, what do you think? What can you see over there? What do you think of the what is the pathology? What do you think of the mucosal wave? What is the glottic closure? Do you think the mucosal wave is symmetrical or not?
Well, in my opinion, ma'am, the glottic closure is symmetrical, but the in the 1/3 anterior part is not quite closing because there is a nodule.
Okay, so do you think it is nodule? Yes. Yeah.
Yes, ma'am.
So now the diagnosis is different. Okay, now we can see clearly the patient has polyp on the left vocal fold. That's why the voice does not improve with speech therapy, with voice therapy. And there is reactive lesion on the opposite side. This is what, when you see the mucus is focusing on the pathology side. The type of closure is hourglass closure. And it is during a glottal cycle, a montage of glottal cycle, it is predominantly open because the closure is affected by edema and vocal fold polyp at the edge of the vocal fold. Now, with the change of the diagnosis, it changed the treatment. Okay, the mainstay of treatment for vocal polyp does not improve with voice therapy is surgery. Okay. So, Haruna, thank you. We are going to move on case number 2. Okay, can I have a volunteer, or maybe Dr. Arfiza want to call a name?
Okay, Prof. I see the audience first. Maybe Munzir in the laryngopharyng division.
Okay, Dr. Munzir is there?
Dr. Munzir?
Yes, doctor.
Okay.
Okay, so ready, yeah? I'm going to play the patient's voice. I don't see Dr. Munzir here. Is he here? Okay, never mind. I'm going to play.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu, saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak, abang dan adik datang menziarahi kami di kampung. Saya gembira apabila mereka datang kerana saya boleh bermain bersama-sama abang dan adik.
His main complaint is dry, irritative cough. He's politician. He has to talk a lot. So whenever he talk about few words, few sentences, he start coughing and then talk again, coughing again. What do you think of his voice? Dr. Munzir? Maybe you're unmute. You have to unmute yourself. Yeah.
Yes, doctor. The roughness is one, doctor.
Okay.
And there's a G2, doctor.
Okay.
Prof.
So if you think roughness is 1, meaning the overall dysphonia is 1. Okay, because you don't have any other component 2, right? You want to rate any component, the breathiness or strain?
No breathing, doctor. Prof.
Nothing. Oh, so if it is 1, it is G1. Yeah, G1, R1, you think B0. So, yep, okay. I agree with you. Sometimes you can hear roughness of the voice, and I think there is some strain in the voice as well. So, Dr. Munzir, if you look at this, the larynx, do you see any issues that may cause roughness? Any structural issues? Can you tell me what is the cause of the roughness component of the voice?
There is a scar in scar or udum, doctor.
Scar, which side?
In the right side, doctor.
Right side, over here.
Yes, doctor.
Okay, I'm going to play the video. Okay, for your information, further history, he never had any surgery done, no neck surgery, no intubation, no accident, neck trauma or anything. Never. He has been healthy, except these voice issues. So what do you think, Dr. Munzir? Do you still think that there is scar, or you have changed your mind after we see the stroboscope of the vocal folds? Stroboscope findings?
No, doctor. Slightly gap in anterior, doctor.
Gap in anterior. Okay, good try. Okay, in my opinion, can you see that the false chord is vibrating together with the true chords? Okay, this is what we call muscle tension dysphonia. Okay, because of the supraglottic squeeze, yeah, the vocal fold, the false vocal fold is like pressing on the true vocal fold until both of them are vibrating. Remember, I show you the previous slide, a normal mucosal wave, a normal vibrating vocal fold. The false chord sit at the side. It does not involve with the vibration. But this one, you can clearly see the vocal folds vibrating together. This is what we call muscle tension dysphonia. So you don't see any structural changes. If you don't have a stroboscope, you would be like, what do you call that, scratching your head. What's wrong with the voice? Why the voice is hoarse? Now you know it is because muscle tension dysphonia. Okay, maybe because he has been abusing his voice, he has been not taking care of the vocal hygiene, okay, and been taking with stress and increased gastric acid production may predispose him to laryngopharyngeal reflux, which is another cause of muscle tension dysphonia, the supraglottic squeeze. Okay, so here you can see that there is mild posterior commissural hypertrophy. There's like edema over here. Okay, and you can't see the ventricle of the vocal fold. Okay, in normal condition, normal vocal fold, when there is no edema, you would be able to see the ventricle. Okay, so there is some signs. There are some signs indicating that the patient may have laryngopharyngeal reflux as well. Okay, so maybe two things that causing this hoarseness. So the treatment we prescribed proton pump inhibitor. Okay, tell the patient not to take any reflux prone diet like coffee, spicy, soury food. Okay, and don't take late dinner. So 4 days after the treatment, the patient texts me saying that thank Alhamdulillah, he can speak now without having to cough every 5 or 6 words, every 1 or 2 sentences. Okay, so thank you, Dr. Munzir. Okay, so what I want to highlight here is, no, you don't see any obvious structural changes, but then the stroboscope help you to diagnose, oh, this is the cause. The muscle tension dysphonia, the vocal folds are vibrating not normally, yeah, the supraglottic squeeze. And if you have speech therapy in your center, you have to send the patient for voice therapy as well, to undo, to make the supraglottic structure that is so tense now, to make it relaxed. Okay. Okay, another case. Can I have a volunteer?
Maybe volunteer better. Maybe we just pointed Prof.
I can see Aditya Pinam. Is he a resident?
Yeah.
Aditya, would you like to try?
Okay, Professor.
Okay. Someone have
Yes, Professor.
Can you unmute first?
Yes, Professor.
If you are the same room with other residents, the other residents have to unmute because there's a lot of echo. Okay. Okay, now there's no more echo. I'm going to play the voice of this patient. Oops. A male teenager with history of intubation when he was a baby due to respiratory issues.
Tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu, saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak, abang dan adik datang menziarahi kami di kampung. Saya gembira apabila mereka datang kerana saya boleh bermain bersama-sama abang dan adik.
Okey, cuba buat begini. Okay, what do you think of the patient's voice?
Okay, Prof. Okay, thank you, Professor. I think from the Graba scale, the roughness of this patient was 3 and the breathiness is 2. So
The overall?
The overall is G3, R3, and B2, Professor.
Okay, thank you. So I agree with you as well. If someone say this is G2, it's also acceptable. And now I'm going to play this video and tell me what do you think, what's wrong with the vocal folds that give rise to this kind of voice. Okay, sekali lagi panjang E 1, 2, 3. Okay, asymmetrical, aperiodic. Okay, what do you think?
I think I can see edema, Professor.
Edema. Which
Yes.
vocal fold?
On the right, Professor. Both of them, Professor.
Okay, all right, good try. But what is obvious over here is anterior glottic web. Can you see that?
I see, Professor.
Yes, there is anterior glottic web. And when we turn on the stroboscopic light, the mucosal waves are asymmetrical, aperiodic, there is no certain tempo, it's all jittery, and the amplitude are reduced bilaterally, especially on the right side of the vocal fold. So this kind of case, when if you're not sure, you can do frame to frame analysis. I'm going to show you a video when we do frame to frame and observe the mucosal wave of the vocal fold. Please observe that there is no amplitude at all on the right side of the vocal fold. There is scar over there. And on the left side, there is small amplitude, small excursion of mucosal wave laterally. Okay. And the waves are also asymmetrical. Okay. Hope you can understand this, Munze. Is that Munze? Sorry. Munze, right?
Aditya, Prof.
Oh, Aditya. Aditya. Okay, Aditya, are you okay with this?
Yes, thank you, Professor.
Okay, all right. Now, we're going to move on to the next case, case number 4. Anyone would like to give it a go? Okay, never mind. This case probably is slightly difficult. I'm going to listen to this patient's voice, yeah?
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan nenek pergi ke rumah ayah.
The voice sounds so like high-pitched, right? It is high-pitched voice. And then when I look at the larynx, I told the patient to cough. Okay, she managed to cough beautifully. Yeah, meaning her glottic efficiency and one of the signs of insufficient or glottic insufficiency is the cough is what do you call that, weak cough, like right? So someone who have high pitched voice like this, we would think like there's problem with the closure of the vocal fold. The patient is compensating by producing high pitch, but instead and I would expect the patient to do, the cough wouldn't be that strong. But when asked the patient to cough, she can cough normally. Yeah, it's a strong cough. Okay, now look at the video of the larynx. There is muscle tension. This one, can you see the supraglottic squeeze? Okay, there is some glottic gap, but not that big. Okay, a small glottic gap during phonation. Okay, so very small glottic gap, and there is some false chord involvement. The supraglottic structure is trying to bring the vocal fold together. Okay, but I wouldn't expect someone who have this finding without any obvious structural issues. The vocal fold look pristine, no lesion. The vocal folds are mobile, is adducting nicely, and there's like slight glottal gap over there. Okay, and there is muscle tension dysphonia. Now we are going to show the stroboscope.
Okey, sekarang nanti bercakap E ya. 1, 2, 3. Okey, sekejap
Okay, so you don't see any vibration, right? So you may want to think that, oh, is the patient is having scar? Okay, but look at the previous slide. The patient has very bad scar, but still there's some little vibration on the vocal fold. Okay, there is some vibration still, but this patient has no vibration at all, with the fact that the very, very small glottic gap. Yeah. I'm not sure whether I have in the slide after this or maybe the next lecture. Unilateral vocal fold paralysis with big gap. There would still some turbulence of mucosal wave. So what happening is this patient is not producing her voice correctly. She's not using air from below. She's using her neck to produce voice. Okay, so we suspect this patient has functional voice disorder. For example, conversion dysphonia, hysterical dysphonia. So I have referred this patient to our speech therapist. So hopefully we would see some results. By the way, the patient have not had any history of intubation, no history of neck surgery, no history of neck trauma, and so on.
Semasa saya masih kecil.
Okay, case number 5. Another patient who, a female, 30-year-old, complained of hoarseness. Similar, no history of intubation, no history of neck surgery, no history of neck trauma. And this is her voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama emak dan ayah dan emak. Setiap minggu saya dan nenek pergi.
So, do you agree with me the voice sounds male voice?
Agree, Professor.
Agree, yes. She is a female, petite, 30-year-old, and the voice like this. It just happened like for 6 months, yeah. And one would say that what could be the differential diagnosis? Someone voice from female become male. Virilization, is it hormonal issues? Is it another possibility, patient had undergone thyroidectomy and the surgeon whacked the external branch of superior laryngeal nerve that would affect the cricothyroid function, and they have husky and bass voice as well. And the other possibility, differential diagnosis, someone voice become virilized, become bass like this, is Rinke's edema. Okay, now we look at the larynx. The larynx looks pristine, okay, meaning there is no obvious lesion. However, she has thick mucus on the larynx. She has bad allergic rhinitis. And if you agree with me, there is some vocal edema can be seen. Yeah, the vocal fold looks baggy. Yeah, looks edematous. Okay, right. And then when we turn on the stroboscopic light, I think, in my opinion, we can see some slight gelatinous material underneath the vocal fold, underneath the epithelium. Okay, see, you observe the vibration. I may be wrong, but I think that is the reason why she has a male voice. Ringkis edema is one of differential diagnosis. We have done thyroid function test, is normal for her. Okay, and I think we are going to send serum testosterone as well, just in case. But then most likely the edema, the ringky edema causing virilization of the vocal fold. So this is the use of stroboscopy. Okay, when other centers is like scratching their head, they use fibroscope. There's nothing wrong. We don't see any cysts, no nodules. Patient have not undergone any surgery to say this is complication of surgery. So when you are managing patient with voice disorders, having stroboscopy is an important tool. Yep. So I think it's already 11:18. How much time we have, Dr. Arfiza?
Maybe 15 minutes, Prof.
15 minutes. Okay. I have another patient. After this, we go through question and answer. Yeah. Okay, I'm going to play some video and I want to get volunteer to guess the diagnosis. Can I have someone?
Maybe Asmelia, maybe.
Yes, doctor.
Okay, I'm going to play the video. Okay, what do you think the problems, the pathology, and what could be the diagnosis?
I think the laryngeal seems, in my opinion, the larynx is oedem. Seems like stenosis larynx, Prof.
Stenosis of larynx. Do you see any lesions on the vocal fold?
In the anterior part, Prof, I see the lesion.
Okay, you stay there. I'm going to further play the video. Where is the lesion?
I'm not sure, but it's...
Do you agree with me? This is abnormal. That one is abnormal. Here is abnormal. And here is also abnormal. Okay. Yes. And the lesion become more obvious when I turn the HD processor light into digital chromoendoscopy, which is eye scan. We're going to talk about that next month. Yeah. The lesion become more obvious. And then this is when I turn the stroboscopic light. You can see that the lesions look supple. It vibrates together with the vocal fold. So when you see this kind of findings, yeah, and stroboscope findings, yeah, you would suspect this patient has recurrent respiratory papillomatosis. Yeah, you can see the dots and the perpendicular vessels over there. And if this is a tumor, glottic carcinoma, it wouldn't be supple, yeah, during vibration. Glottic carcinoma, it's normally firm and it wouldn't be in multiple sites like this. There is also on the false cord, yeah, on the false cord over here, and the true cords as well. Okay, so the provisional diagnosis when you see like this is RRP, recurrent respiratory papillomatosis. And on stroboscope, do you think the mucosal wave is symmetrical? Definitely no. You don't see mirror image. Yeah. Remember the slide? You say the mucosal wave is symmetrical when you see nicely right and left, symmetrical, like a mirror. And the amplitude is also not normal. Yeah, the amplitude is markedly reduced because of the lesion, yeah, on the vocal fold. Okay. So I know it's too much for you to understand to be good within one lecture, but I'm calling you so that you start thinking. Yeah, you start thinking. I don't blame on you if you get a wrong answer because we are all learning. Yeah. Right. So another last one. Can I have another volunteer? Maybe this residents from first year to fourth year, right, Dr. Arfiza?
Yeah.
We get the final year, the fourth year resident to answer.
Okay, maybe email. They want to go to the exam, broad exam, maybe.
Yes, sir.
Okay.
Okay, I'm going to play the video and tell me the findings and your diagnosis. Okay, what do you think?
In my opinion, Prof, there's a mass in the anterior vocal cord bilateral, but that fixate the anterior vocal cord, but the posterior vocal cord still be able to do a glottic closure, Prof.
Okay, so what do you think the diagnosis?
I suppose it's a tumor, probably a carcinomatous in vocal cord bilateral, Prof.
Okay, so I'm going to further play the video. Yeah, stay there. Keep on observing the video. Lama-lama. Sekejap sudah tak tengah-tengah. Ada. Macam lagi lama-lama I. Okey. Lagi lama-lama I. Lagi. Now, do you want to change your findings?
I think there's an asymmetrical vocal cord movement, Prof, and there's appear to be edema, Prof.
Yes, edema of the
in the superior of vocal cord, Prof.
Okay, now Amelia, right? Right. This is what? Who is this? Amelia. Azmelia. Emila. So now Emila, you look here. This is false cord.
Yeah,
that one is false cord. And the one that is flabby, that we thought flabby false cord earlier, is actually polypoidal mucosa that come from the vocal fold. Yeah, the diagnosis is Rinke's edema. Look carefully. Can you see the false cord here? That is the false cord. That one is the false cord. And the one that is vibrating is the polypoidal true vocal fold. Can you see that? And this patient has vocal fold, has Rinke's edema. Okay?
Yeah,
so I think we finished that. I have other slide, maybe if we have time next time. Okay. Yep, we go to conclusion. Sorry. Videolaryngostroboscope, yeah, is an important tool in assessing vocal fold patients with voice disorder. Hope with some cases that I've shown you, you understand, yeah, the importance of having stroboscope, the importance of examining the mucosal wave, because it can tell you a lot of things that cannot be told by the simple laryngoscope without stroboscope light. Laryngoscope combined with stroboscope light allow assessment of vibration characteristic of the vocal fold. And if you use a video endoscope rather than 70-degree scope, it will enhance patient's cooperation. And furthermore, you can bring the tip of the camera. You have seen, I bring the tip of the camera as near as possible to the vocal fold. So you have personal examination, personal touch. Yeah. Okay, so we stop there. I take questions.
Okay, thank you, Prof. Maybe we will cut for the question. There's one question. Okay, this question was from Ivani Putrisari. Dear Prof, in case we don't have any videolaryngostroboscopy, how could we diagnose muscle tension dysphonia? Is it accepted making suspecting MTD diagnosis by videolaryngoscopy only?
It is a good question. Yes, of course. If you don't have stroboscopy and you see a supraglottic squeeze, you still can diagnose muscle tension dysphonia. Okay, it's just that when you have stroboscope, you can see the vibration of the vocal fold, the false chord, which enhance your diagnosis. And number two, you really want to look carefully at the vocal fold before you say this is just a muscle tension dysphonia due to laryngopharyngeal reflux. And that clearly the patient have hoarseness component in the voice. You want to know whether you are missing any subtle lesions, maybe early mucosal lesion, yeah, any probably intracaudal cyst that which is not obvious on the epithelium, then you would need a stroboscope. So the question, if I answer the question, can you diagnose muscle tension dysphonia using videolaryngoscope without stroboscope? The answer is yes. But you may miss some other lesions, yeah, to point out, is it just that muscle tension dysphonia causing the hoarseness, or there are other things, subtle things on the vocal fold, true vocal fold, that you do not want to miss.
Okay, thank you, Prof. There is another question here from Inanda. What are the factors that determine the success of videolaryngostroboscopy examination, Prof?
Okay, the factors, number one, you have to be comfortable with your scope. Number two, the patient has to be comfortable. You have to identify which anxious patient, which are patient who are cooperative in the clinic. If you see the patient is super anxious, you have to tell the patient what you want to do. First, explain. Anesthetize the patient carefully. Yeah, anesthetize the nose, spray the oropharynx, and you may want to give supraglottic anesthesia as well, which will be covered in a different lecture. And when you spray the patient, wait until the anesthetic agent work. Yeah, many residents in my place as well, they are they have basic clinic, they have many patients, they spray and immediately they put the scope in. The anesthetic agent has not worked yet. The moment you take out the scope, only then the patient feel kebas, feel numb inside. So that's not correct. Yeah, you have to wait for about 1 minute. Okay. And number three, you have to position the patient. You have to position the patient have to be slightly forward like that with chin out, yeah, to expose the larynx. This is particularly important in patients who have anterior larynx. I'm sure you have experience when you put scope in, the epiglottis is covering the vocal fold. So by doing this, you open up the larynx. And when you advance the scope to be as near as possible to the vocal cord and to the laryngeal structure, do not touch the laryngeal components, the laryngeal structure, like especially the epiglottis and the arytenoid. The moment the patient can feel it, they will start gagging and coughing. So you need some skill. You need to do again and again. Every time you scope patient, you try to adhere a good practice and try to develop your own skill. How can you perform this examination with a good patient cooperation, and you manage to bring the tip of the camera as near as possible. Anesthesia is a key, yeah, and patient's understanding. I have a patient that, you know, the French girl who come with hoarseness. At first, she refused. She did not let me to put scope in because she said she almost fainted, yeah, when she was scoped outside in other hospital. So I have to calm her down. I said, I promise you, I'll do it this carefully. I spray your nose, okay? I will do my best so that you wouldn't feel it, or just very minimum sensation in the throat. And in the end, she's happy and she willingly to let me scope again whenever she come for follow-up. So your rapport with the patient is very important.
Thank you, Prof.
Welcome.
There's another question.
Sorry, is that answer your question, Inanda? You have further question with regards to the same thing?
Yes, Prof, very clearly. Thank you, Prof.
Okay, welcome.
Okay, thank you, Prof. Maybe another question is similar to the first question, the second question. I would like to ask the preparation needed to be made before the videolaryngostroboscopy examination, Prof.
The preparation is not massive. It's not like you are doing OGDS and the patient have to be sedated, and it's like your usual laryngoscopy in the clinic. It's just that you are coupling another light source, yeah, for you to see the mucosal wave. Regardless if you do laryngostroboscopy or you do laryngoscopy without stroboscopy, the technique is the same. Okay, let's say you don't have stroboscope, you only have video endoscope, yeah. You have to bring the scope as near as possible for you to be able to see, to do personal examination, because a lot of findings will tell you what's wrong with the patient. Okay, and you would be able to see ectatic vessels, small nodule, yeah, things like that, yeah, which you wouldn't be able to see if you keep your scope very far at the tip of the epiglottis. Does it answer the question, Munzi, or you want to ask further about this?
Munzir? Maybe the answer is...
Okay.
Yeah, Munzir?
Yes, Dr. Clearly, Doctor. Prof, thank you, Prof.
Okay. So anyone would like to ask the vocal fold pathology that I have shown? Anything not clear, please ask.
This is only the discussion, so don't be afraid to ask Marina about the videos laryngostroboscopy.
If you're not clear, you don't understand, you better ask now, because the next time you're going to a different lecture, not the same topic anymore.
We still no question. Is there any question? If you want to directly ask the Prof Marina or in the chat box, also can be done.
I would like to ask a question, sir, Prof. I would like to confirm that in the muscle tense dysphonia cases before, you mentioned about scar on at the pathology on the vocal cord. Can you show us again, because I did not recognize? Thank you, Professor.
Thank you, Chairuna, yeah? Chairuna. So I did not mention vocal fosca. Vocal fosca was mentioned by one of the residents. I can't remember who. So actually there's no vocal cord scar. There's no, that's why, you know, at first your friend thought that there is vocal cord scar. Okay. And whenever we turn on the stroboscope, we can see clearly there's vibration. There is no non-vibrating segment. It's all vibrating. It's just that there is involvement of the false cord, and instead of just the vocal cords vibrating, the false cord also vibrate together because it becomes very near and it's touching the true vocal fold. Okay, there's no scar. Okay, that's why you can't see it. You're right, there's no scar.
Thank you, Professor. Just want to confirm it. Thank you.
Okay.
Another one to ask Prof. Marina directly, or chat box maybe? Okay, there's one question again. I would like to ask how the role of Videolaryngostroboscopy in voice evaluation for laryngeal carcinoma, Prof?
Okay, thank you for the question. Number one, okay, the best is if we can catch the diagnosed laryngeal carcinoma, particularly glottic carcinoma, very, very early. Okay, sometimes without stroboscopy, a very small lesion may be missed. And when we turn on stroboscopic light, when you see there's non-vibrating segment, the abnormal mucosa become more enhanced, then you know, oh, there is a lesion over there, which you may want to target removing it under general anesthesia. That's number one. Number two, by using the stroboscope light, assessing the mucosal wave also may tell us how deep is the infiltration of the lesion. Okay, let's say it is just a superficial lesion on the epithelium. It has not invaded the vocal ligament. Okay, so you may still see the mucosal wave, okay, but with reduced amplitude because there is a mass on the vibrating mucosa. But someone who have lesion that seemed superficial but actually ulcerative, and it has involved the vocal ligament, okay, you would see that segment not vibrating at all. You don't see that nice soft curtain effect from medial to lateral, like other parts of the vocal fold. Then you suspect, if this is tumor, okay, it has involved the vocal ligament. So in cases where you want to do excisional biopsy, where you want to do biopsy, diagnostic, as well as therapeutic, you do cordectomy at the same sitting, you want to remove the vocal ligament as well to make sure that, the surgical margin is addressed, yeah, in removing the lesion. Okay, does it answer the question? Any further question from there about laryngeal carcinoma?
It's enough. Thank you so much, Prof.
Welcome.
Okay, there is question, Prof. When we decide to patient need to do a videolaryngostroboscopy examination.
Okay, if you have stroboscopy in your center, you would want to do stroboscopy examination in all patients with voice disorder who come through your clinic complaining of voice issue. Okay, let's say a patient come with unilateral vocal cord paralysis. Although you can diagnose unilateral vocal cord paralysis without doing stroboscope, but examining the mucosal wave will help you in certain cases. Plus, if you have a stroboscopy, you can perform examination before intervention and after intervention to see how good is your surgery, how good is your intervention in returning the mucosal wave of the patient. Okay, maybe because I did not show the slide on vocal cord paralysis, maybe I show that slide. Okay, let me show the slide. Okay, like this patient, yeah. This patient, a 45-year-old female pharmacist who had thyroidectomy long ago, 4 years ago, 4 years before she saw me in the clinic. And she was diagnosed with a left vocal cord palsy complicated by the thyroidectomy. Her voice slightly improved after voice therapy, but still inadequate for her because as she is a professional voice user, pharmacist, she needs to use her voice a lot. And this is her voice. Yeah.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu, saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar,
so if you agree with me, there's not much of breathiness component. The main component is roughness in her voice. So it makes you think. So if the patient has unilateral vocal cord palsy, she's struggling with her voice, she should have a breathy voice rather than rough voice, right? So then you perform videolaryngostroboscopy. So what information you get from here? Number one, the mucosal waves are asymmetrical, okay? And she doesn't have complete closure, okay? Although the voice sounds rough, but probably is a compensatory mechanism for her to produce voice. So from the stroboscopic examination, you can see that the amplitude, the mucosal wave is asymmetrical. There is reduced amplitude on the palsy side, and the duration is closure is predominantly open. So in this case, maybe at first without stroboscope, you don't see big glottal gap. You are quite unsure what else can you offer to the patient since the glottal gap is not huge. But after seeing the stroboscopic examination, I think the patient would benefit of type 1 thyroplasty. Or if the patient do not want open procedure, we can do injection laryngoplasty to close the glottal gap so that the patient can project her voice better. And after you have done the operation, you repeat the stroboscopic examination and you observe the mucosal wave, how much it has improved the mucosal wave. So at the end of the day, number one, you can inform the patient how much improvement that you have caused to the vocal fold. And number two, if you are doing something new or you want to collect your own experience, later on you can present your data. How much this particular intervention help in patient with unilateral vocal fold paralysis, particularly in a stroboscopic evaluation. Yes, particularly how much it has improved the generation of mucosal wave. How much normal mucosal wave that you can achieve after you have performed the surgical intervention. So to answer that question, for myself,
MAT.
So if I have stroboscope, I would do all patients with voice disorder. But if you are in the center, do not have a stroboscope, you may want to choose patients whom you are not sure what is the diagnosis. Okay, you can't see, maybe you patient has hoarseness, but there is no an obvious lesion. Abdominal pathology can be seen on your videolaryngostroboscopy. So you may want to refer this patient to other center that has stroboscopy to ensure what is wrong with the vocal fold, why the patient's voice is like that. So in Western countries, in developed countries, having stroboscope in voice clinic is compulsory. They should not run voice clinic without stroboscope. And you, for example, you have patient vocal cord cyst although you can diagnose vocal cord cyst with videolaryngoscope, but then you know that one of the complications of vocal cord cyst is scar. So prior to surgery, you would want to examine, and you use stroboscope to examine the mucosal wave. Let's say probably the patient preoperatively already have vocal cord scar. You wouldn't know. So, and then if you see the vocal fold is supple, there's no scar, you do the surgery, and during follow-up, the patient complain, still my voice is hoarse, not back to normal, and you use the stroboscope to look whether is there any scar that developed as a complication of the vocal cord cyst excision. Okay, I hope that answered the question. And yeah, okay.
Okay, it's answered the question. Maybe another question. I would like to ask the condition that contraindicate the videolaryngostroboscopy.
The answer is no contraindication. It is like performing your videolaryngoscope. It just you turn on the light and then you get more information by having a stroboscope in the system. So unless if videolaryngoscope is contraindicated in that patient, then videolariнгоstroboscope is contraindicated. I give an example, a patient where the moment you put scope in the nose, the patient faints. Patient ada some panic attack, very anxious, patient tend to get vasovagal attack. The moment you put scope in the nose, then it is contraindicated. Too bad for the patient. Yeah, we can't. You only can examine the vocal cords under general anesthesia.
This another question from the Ifani. Prof, will you kindly share about the presbyponia in videolaryngostroboscopy examination?
Okay, good question. So for you to diagnose puberphonia, this presbyphonia. Presbyphonia is atrophy of the vocal fold due to aging, right? Due to aging. So in videolaryngostroboscopic examination, okay, you would say, no, I start with videolaryngoscope first. Let's say you don't have stroboscope. What you would be able to see is bowing of the edge of the vocal fold because of atrophy. The vocal process become prominent, and when the patient phonates, there would be a small gap, glottic gap. Okay, and when you turn on the stroboscopic light, sometimes things that you can't see on videolaryngoscope, the thing that I mentioned just now, the vocal process, bowing and things like that, will be accentuated in a stroboscopic examination. Plus, you would be able to see that the mucosal wave is asymmetrical and reduced amplitude due to the glottic gap and atrophy of the vocal fold. The atrophy is not the superficial lamina propria. The atrophy is the body, the muscle, which becomes smaller in volume due to aging process.
Okay, Prof. Do you have any video of that, Prof? Because she wants...
I did not include in my PowerPoint. Maybe next time.
Okay.
Yeah.
Is there any question? Maybe 10 minutes before we are closing.
Maybe that's it.
Yeah, maybe that's it.
Yeah.
There's no question. Maybe we will close this meeting. Maybe Dr. Andrina can close the meeting.
Yes, Dr. Arfiza.
Thank you.
Very, very informative and attractive, Prof. Thank you very much. Ya, di akhir acara ini saya ingin mengucapkan kembali ucapan terima kasih, penghargaan setinggi-tingginya untuk Prof. Marina, sudah sharing so many knowledge and experience for us. Thanks a lot, Prof. mudah-mudahan menjadi bermanfaat bagi kita semua in our daily activities. Ya, jangan bosan-bosan ya, Prof. Kami tetap berharap Prof masih bersedia sharing ilmu untuk kita semua. Keep healthy, tetap menjaga kesehatan. Di Indonesia masih tinggi, Prof, Omikron. Bagaimana dengan di KL?
Di KL, di Malaysia begitu juga. Naik 30,000. Sudah penat.
Iya.
Penat untuk mengira.
Almost 3 years.
Ya.
Ya. Ya, Prof.
Cuma bezanya ramainya di dalam kategori 1-2.
Oh. Iya.
Bukannya seperti tempoh hari di mana ramai di ICU ya. Ini ramainya kategori 1-2.
Ya, kita tetap jaga kesehatan, mudah-mudahan selalu dalam lindungan Allah Subhanahu wa taala ya, Prof.
Insya Allah.
Kita berjumpa kembali di next session dalam keadaan sehat walafiat. Terima kasih Prof, terima kasih Dr. Arfiza, Dr. Devira, dan seluruh peserta kuliah tamu hari ini.
Foto Dr. Andrina.
Oke, ya, silakan.
Izin dokter, izin Prof, akan saya bantu untuk screen capture pada pagi hari ini. Saya akan foto dalam 4 kali dan dalam hitungan mundur, dimulai dari yang pertama. Dimohonkan kepada seluruh peserta untuk mengaktifkan kameranya. Mohon dokter, abang kakak, profesor sekalian. Izin saya menghitung mundur. 3, 2, 1. Untuk yang kedua, 3, 2, 1. Selanjutnya 3, 2, 1. Yang terakhir 3, 2, 1. Terima kasih Prof. Dokter.
Terima kasih Prof.
Thank you for having me. Oh, saya nampak Ezzy di sana.
Dr. Ari juga ada nggak Prof?
Siapa?
Dr. Ari.
Hari? Tidak nampak.
Prof Marina, nice to you. Thank you.
Oh, Prof Bambang, apa kabar?
Thank you for supporting our activity now.
You're most welcome. Happy to do that.
Yeah.
Menyebarkan ilmu.
Yeah, still in good health, ya.
Yeah, you too. Stay safe, everyone.
Ya.
Ada satu rongga yang dikenal sebagai rongga paru-kari.
Saya
selamat ya, sukses acaranya.
Belum bisa
Alhamdulillah, Prof.
Nampak Dr. Novialdi juga.
yang berada di antara lobus fasial.
Always melakukan pembedahan hari Sabtu ya, Dr. Novialdi.
Iya, Bu. Ada kegiatan satu lah.
Okey, so saya tinggalkan meeting ya. Terima kasih, bye-bye semua.
Terima kasih Prof. Terima kasih Prof Bambang, Dr. Ezi.
Ya.
Terima kasih Dok. Terima kasih.
Maka ada landmark kedua yaitu vena retromandibula sinis